So seizure is basically the clinical manifestation of an abnormal and excessive excitation of a population of cortical neurons, or it can be defined as episodes of the temporary brain dysfunction which are secondary to abnormal electrical activity in the brain, or episodes of neurological dysfunction in which abnormal neural excitability or firing is manifest clinically by changes in motor control, changes in sensory perception, changes in behavior or autonomic function. So not necessarily in a seizure you will see that patient has some motor jerking or chronic posturing or something like that. Sometimes seizure can be only abnormal transient sensory perception or abnormal brief behavioral disturbance or autonomic dysfunction for a transient period. It can be a seizure. So usually at your student level or at undergraduate level, people think that seizure is only what looks like an abnormal jerking movements of the body. It's not so. And what is epilepsy? Epilepsy is basically tendency towards recurrent seizures which are unprovoked by any systemic or acute neurological insults. Or you will say two or more unprovoked seizures. So unprovoked seizures, you must know what is provoked seizure and what is unprovoked seizure. Seizures which are provoked by any acute systemic or CNS insult, they are not categorized in epilepsy. For example, patient with viral encephalitis, brain infection, you may have seizures. But these patients are not labeled epileptic patients because once you treat viral encephalitis, there are very minimal chances of those patients to have recurrent seizures which are classified in epilepsy. Similarly, for example, electrolyte imbalances, hypocalcemia, and other electrolyte imbalance in the blood can sometimes acutely lead to seizures. But again, this is not classified in epilepsy because they are provoked by some acute systemic or CNS insults. So epilepsy is that which is a recurrent seizures tendency and which is unprovoked by any systemic or acute neurological insult. Epileptogenesis is basically the sequence of events that converts a normal neuronal network into a hyperexcitable network. For example, in patients with head trauma, in the long term they may develop fibrosis, and those fibrosis in the neuronal network can produce some type of abnormal transient excitability leading to epilepsy. So epileptogenesis is that sequence of events that converts a normal neural network into a hyperexcitable network. What are the parts of seizure? Aura, part that is preceding the actual seizure activity is aura. Ictus or ictal period, during which you will see the actual manifestation of seizure. That may be motor, there may be sensory, that may be autonomic, as we discussed. Post-ictal period is a period immediately after cessation of actual seizure activity, and interictal period is a period between two seizure activities. Briefly about epidemiology, prevalence of epilepsy is 0.5 to 1 case per 100. You can see how common this problem worldwide is. Very common neurological disorder and worldwide very common disease. Seizures are common, affecting approximately 10% of individuals at some point in their life. You can see the difference here between epilepsy and seizures. Epilepsy is about 1 case per 100, but seizures in lifetime 10% of people will have some form of seizures, but they are not necessarily epileptic seizures. For example, many patients at young age have febrile seizures or because of some other acute electrolyte imbalances. So seizures chances are much more common than having an epilepsy in patient. Approximately 25% of seizures are acute symptomatics or provoked seizures that do not have tendency to recur, that we discussed now. Incidence of partial seizures increases with increasing age because with increasing age there are more chances of having brain trauma, having stroke and other brain insults. So partial or focal seizures increase with increasing age. Complex partial seizures are the most common form of seizures in adults. In 60 to 70% of people with epilepsy, no cause can be found. So 60% of patients have idiopathic epilepsy. Pathophysiology, we will discuss some key concepts, how an abnormal excitation develops in the brain leading to epileptic seizures. Causes of epilepsy are many, but the fundamental disorder is secondary to abnormal synchronous discharge of network of neurons. Abnormal synchronous discharge. Epilepsy is secondary to either abnormal neuronal membrane transmission or an abnormal balance between excitatory and inhibitory synaptic potentials. So either the neuronal membrane transmission defect or synaptic transmission defect, this can lead to abnormal discharge in the neurons. A hyperexcitable state can result from increased excitatory post-synaptic neurotransmission, decreased inhibitory neurotransmission, and alteration in voltage-gated ion channels or alteration of intra or extracellular ion concentration in favor of membrane depolarization. So this is basically, these are the basic level concepts that you must have understood at your basic physiology level in first year, second year MBBS physiology level. These neuronal transmissions, and these are in more details. I will just get this review in the context of epilepsy. Some regions of the brain, for example hippocampus, anterolateral cortex and amygdala, mesial and mental temporal lobe, they appear to be more vulnerable to epileptogenic process. Abnormal neural membrane transmission or abnormal neural membrane conductance. As we discussed, either neural membrane defect or synaptic transmission defect can lead to abnormal neuronal firing. What is resting membrane potential? Again, basic physiology level concept, you must be aware of this. It is basically the voltage difference between inside and outside of neural cell membrane. We know the extracellular space is dominated by sodium and chloride ions, whereas potassium, proteins and organic acids are found intracellularly. So intracellular is more negative. Lipid bilayer of the neuron, basically it acts as a barrier to the diffusion of ions. So net of excess positive charges outside and net of negative charges inside, they produce a resting membrane potential of around 50 to minus 80. This is, you can see more negative ions inside, positive and outside, and this lipid bilayer basically it acts as a barrier to their free movement and maintains a resting membrane potential of minus 70. Here you can see, you take a piece of neuron, and if you check its resting membrane potential, you will see the difference between outside and inside the membrane, and that difference is around minus 70 microvolts. So resting membrane potential is maintained by these voltage gated channels and ion channels basically. Otherwise sodium and potassium cannot diffuse across bilayer. So these channels and gated channels and voltage channels, they basically maintain and produce depolarization. A reduction in the negativity of this polarized state is called depolarization. Means depolarization of the wave when there is excitation, while increase in the negativity of resting membrane potential is known as hyperpolarization. Abnormal membrane potential permeability that changes and allow sodium to enter the cell lead to excessive depolarization and clinical seizures. So more depolarization, more abnormal excitability, and leading to seizure manifestation. Again, this is the same concept that we of basic level. How this is action potential looks like. Resting membrane potential, when it resting membrane potential by ion and other channels, depolarization occurs because of opening of voltage gated sodium channels. Here you can see, and depolarization waves occurs. And again, after depolarization there is a repolarization, which is because of closure of sodium channels and opening of potassium voltage gated channels. One says Ritchie's baseline, hyperpolarization briefly occurs because of voltage-gated potassium channels. This is the action potential of a neuron. As I discussed, either there is membrane transmission defect or there is abnormal synaptic transmission. This abnormal synaptic transmission can also cause abnormal excitability and seizure formation or epileptic seizures. Major neurotransmitters in the brain, as we know, are glutamate, which is excitatory, GABA, which is inhibitory, acetylcholine, other norepinephrine, dopamine, serotonin, histamine. These are also present in the brain synapses. Two major types of synaptic receptors are inotropic receptor and metabotropic receptors. Again, these are the basic level concepts. You must be aware of the receptors for these synaptic neurochemicals are either inotropic and metabotropic. Inotropics are what? Which directly alter the conductance of the ion channels when bound to a neurotransmitter. For example, GABA1 neuroreceptors, they increase chloride conductance and hyperpolarization when GABA neurotransmitter binds to it, leading to inhibitory postsynaptic potentials, while it produces excitatory postsynaptic potentials when excitatory neurotransmitters such as glutamate bind to it, producing depolarization. Whether a neurotransmitter generates an action potential is determined by the relative balance of excitatory and inhibitory postsynaptic potentials. As you see, excitatory postsynaptic potentials in which depolarization occurs and response becomes stimulatory, while these inhibitory postsynaptic potentials that further hyperpolarize the membrane, they basically cause what? Response inhibitory, and they decrease abnormal excitation. Metabotropic receptors are the receptors that activate a second messenger system, G proteins, where a neurotransmitter binds to it. These activated G proteins may then open an ion channel or activate an enzyme to ultimately depolarize or hyperpolarize membrane potential. Examples include GABA2 receptors, peptide catecholaminergic receptors, and glutamate receptors. What are the causes of epilepsy? Now, coming to major concepts, causes of epilepsy, as I discussed previously, majority of the cases there is no cause. These are called idiopathic, and most of them, they are presumed to be genetic. As you can see, 68% of patients, there is no underlying cause of epilepsy. In only 30 to 35% of cases, you will find underlying secondary or symptomatic cause that include, for example, tumor, trauma history, patient having previous stroke history with subsequent development of scar epilepsy, infections, autoimmune diseases, and other diseases. So this is same cryptogenic idiopathic epilepsy. This is the major cause of epileptic seizures, in which there is no underlying cause can be found, and majority are presumed to be, again, genetic in origin. And 10% of cases you will find vascular cause, stroke for example, congenital abnormalities in the brain, trauma, tumor, degenerative diseases, infection. These are other causes for secondary seizures. So important etiologies of secondary seizures, as we discussed in the graph. Tumors, for example, a very important cause, vascular event including subarachnoid hemorrhage, subdural hematoma, or epidural hemorrhage, stroke, vasculitis, infection, meningitis, encephalitis, abscess can cause secondary seizures. Metabolic disorders, hypoglycemia, hyponatremia, hypomagnesemia, hypocalcemia, toxic causes, cocaine and symptomimetics, they can cause an increased excitability of neurons leading to epilepsy. Tricyclic antidepressants, anticholinergics, theophylline, eclampsia and pregnancy. These are the causes of secondary seizures. Here you will see the T2 weighted images of MRI brain, and you can see if patient is having some seizure activity, recurrent seizure activity on imaging, you can find such causes. These are the causes of secondary epilepsy. And you will see that in primary epilepsies, or in majority of cases, their MRI will be perfectly normal. So as here, for example, you can see here, this is ischemic area because of previous some ischemic insult leading to stalk formation, scar formation, and it can cause recurrent seizure activity, which is called scar epilepsy. Tumor, for example, here with surrounding edema, it can also cause abnormal excitability in the neurons and abnormal neural activity leading to seizure activity. Here you will see that this sclerosed or fibrosed area in medial temporal area, which is called mesial temporal sclerosis, is also a very important cause of secondary seizures. What is EEG potential? EEG potentials are basically recorded EEG potentials which arise from extracellular currents flow from summated excitatory and inhibitory postsynaptic potentials. EEG does not record activity from a single neurons. You must be aware of that when we do electroencephalogram, EEG on the brain, like we do pick abnormal, like on ECG, electrocardiogram, you are picking polarization, depolarization and currents from cardiac activity. Similarly, from brain, you can extract this electrical activity when you place electrodes on the scalp. And this electrical activity is not actually from a single neuron, but it is dependent on summation of thousands to millions of postsynaptic potentials. Therefore, it represents activity from a large neuronal aggregation. During seizure, when a synchronous firing of large aggregation of neuronal cell occurs, action potentials may contribute to EEG changes. Normally, you will see there is electrical activity, but sometimes during seizure, that electrical activity will be abnormal. For example, in myocardial ischemia, you will see abnormal Q waves in ST formation. Similarly, in EEG, there will be changes that will suggest that this is abnormal neuronal excitability. For example, here is normal EEG, you see the normal electrical activity over here, but during seizures, this burst of electrical activity, it represents abnormal activity during seizure. These are different types of abnormal electrical activity which are picked on EEG, and I think it is not at your level. Sometimes spike activity, sharp activity, spike in wave activity. These are all the types of abnormal neuronal electrical activity which can be picked on EEG. What are the seizure risk factors? These are the factors. If they are present, there are increased chances of having epilepsy. For example, if there is history of prenatal and birth injury, history of febrile convulsions, developmental delay, history of head trauma, history of sinus infections, brain tumors, brain surgery, or family history, these increase a person's tendency to have epilepsy. Now, about classification, two types of classifications are used. The one which is very common and we routinely discuss in our lectures is based on epileptic seizure types. Another is based on etiology, either idiopathic, symptomatic, or cryptogenic. This is on the basis of a seizure type that we routinely discuss. Either seizures are partial or generalized, again partial, simple, complex, or secondary generalized. But this old classification is now replaced by a newer classification, you must know, and that was revised in 2017. Simple partial seizures or complex partial seizures are no longer mentioned. They are categorized in one category called focal onset seizures, either general onset, generalized onset seizures, or focal onset. So focal onset seizures, in that you will see the focal activity is with impaired awareness or with intact awareness. If there is intact awareness, it is equivalent to old classification of simple partial seizures. If focal activity is with impaired awareness, it is equivalent to old classification of complex partial seizures. So focal onset seizures, first thing you have to know is the awareness is intact or not. If it is intact, then you must see it is of motor onset, non-motor onset. Focal seizures with motor onset can have automatisms, atonic seizures, tonic, epileptic spasms. Non-motor onset, you may have autonomic, behavioral arrays, cognitive, emotional, and sensory. But in all these, the awareness should be intact if it is simple focal seizures. If it is impaired, it is really complex partial seizures or impaired awareness with focal onset. Previously, secondary generalized seizures, now they are called focal to bilateral tonic-clonic seizures. Generalized seizures again are classified more detailed, either motor or non-motor. Motor tonic-clonic, clonic activity, myoclonic, tonic-clonic, myoclonic atonic and epilepticus spasm. And non-motor seizures, for example, very common absence epilepsy you will see in children. It may be typical, it may be atypical, it may be myoclonic, eyelid myoclonia. These are non-motor seizures. And there's also third category in expanded version, which is called unknown onset. Again, that you will see whether it is motor or non-motor. There are many seizures which are still not classified. They are categorized in unclassified. These are the phases of the ictal activity. You see the phases of generalized tonic-clonic seizures, in which initially there is tonic posturing, as you can see here, tonic posturing of the limbs occurs. Later on, this jerking of limbs occurs, that is called clonic activity. And after that, after stoppage of this seizure activity, this is the post-ictal state when the patient lies unaware or unconscious. So initially there is stiffening of body or tonic posturing, later on clonic jerking, and this is post-ictal state. This is example of absence epilepsy common in children. As you can see child reading on the books, but there is abruptly and sudden and brief cessation in activity when this absence seizure occurs, and it will return to normal within seconds. Another example, child playing with the ball, and there is sudden cessation of this normal activity leading to fall of the ball, but this should be returned to same baseline normal within seconds. This is a very common presentation of absence epilepsy. Other classification that I discuss is syndromic classification of epilepsy, which is designed to classify syndromes in which types of seizures are not but not the only feature of syndrome as in previous classification. Other features such as etiology, age at onset, genetics, and evidence of brain pathology are also included in it. It is more helpful for prognostication and optimal management of seizure disorder. At the level of clinicians like us, this classification is very important, but for undergraduate level, at your level, the first classification of seizure type is very important. So this syndromic classification is divided in idiopathic epilepsy syndromes and symptomatic epilepsy syndromes. So idiopathic epilepsy syndrome again are divided in focal or generalized. Idiopathic are those there is no underlying cause which can be found on detailed imaging and other studies. So focal idiopathic epilepsy syndromes include rolling epilepsy, benign childhood epilepsy with occipital paroxysms, autosomal dominant nocturnal frontal lobe epilepsy, familial temporal lobe epilepsy. Generalized epilepsy syndromes, generalized but idiopathic. They include very common disease of childhood, juvenile absence epilepsy, juvenile myoclonic epilepsy, epilepsy with generalized tonic-clonic seizures, epilepsy with the myoclonic aesthetic seizures. This is basically generalized idiopathic epilepsy syndrome, means there is no underlying cause which can be found. Then there is symptomatic epilepsy syndrome, in which you will find some underlying cause. Symptomatic is again divided into focal and generalized. Focal temporal lobe epilepsy, and you will see on imaging that there will be hippocampal sclerosis on brain MRI in this temporal lobe epilepsy. Frontal lobe epilepsy from various frontal lobe itself. Rasmussen syndrome, which is also called epilepsy partialis continua, which is an autoimmune disorder. Landau-Kleffner syndrome, which is acquired epileptic aphasia, post-traumatic epilepsy, scar epilepsy. So these are focal symptomatic epilepsy syndromes. And there are also generalized symptomatic epilepsy syndromes, for example, West syndrome in children, Lennox-Gastaut syndrome, Ohtahara syndrome. These are categorized in generalized symptomatic epilepsy syndromes. How you diagnose epilepsy? Goals for diagnostic evaluation in epilepsy are establishing a diagnosis of seizure-specific epilepsy syndrome, etiologies, diagnosis of seizure disorder, and precipitating factors. So first you must define what seizure type it is. Then you must see for underlying etiology. Then you must see whether there are precipitating factors for seizures or not. And this is achieved with history taking, physical examination, imaging, EEG changes in laboratory examination. So to define or to diagnose a proper epilepsy syndrome, you must do all these things: history taking, physical examination, detailed imaging studies, EEG, and laboratory examination. Very important differential diagnosis for seizures. So differential diagnosis for seizures or epilepsy is any disorder which is transient abnormal manifestation. Like seizures have transient abnormal neuronal manifestations, so any disorder having transient abnormal neuronal or neurological manifestations can mimic seizure activity. For example, migraine have aura, which is a transient neuronal activity, and that can mimic seizures. Similarly, syncope can mimic seizures. Transient ischemic attacks, in which transiently patient may have motor or sensory symptoms, so it also mimics seizure disorder. So depending on history, examination, imaging, you will be able to define either seizure activity or this is transient ischemic attack. Sleep disorders, many children and adults can mimic seizure activity. Rage attacks in children can sometimes mimic epileptic syndromes or epilepsy. And there are very common category of non-epileptic form psychogenic seizures. This is not epileptic form type of seizures, but these are more type of psychogenic seizures. So these are very important differential diagnosis of seizure disorders in any patient. I think this is not at. So seizures, if you say paroxysmal events, they can be non-epileptic form, they can be epileptic form or epileptic seizures. Not necessarily every paroxysmal event is seizure. There are non-epileptic events as well and epileptic seizures as well, but again in epileptic you have to see whether it is provoked or unprovoked. This unprovoked category is called epilepsy. These other all are not epileptic disorders. For example, seizures provoked from alcohol, lack of sleep, drugs, metabolic causes, fevers, infections. These are not categorized in epilepsies. Unprovoked seizures from many causes having recurrent tendency are called epilepsy, and again if that you have defined it, there are recurrent epileptic seizures, then you must know whether it is focal onset or it is generalized onset. First of all, you must establish a diagnosis of epilepsy before management. Provoked seizures, as we discussed, or acute symptomatic seizures are managed for a short period, while symptomatic seizures need long-term management. Age, gender, pregnancy, comorbid conditions, and drug-drug interaction should be kept in mind before starting long-term anti-epileptic therapy. There's a category of drugs. First generation, the older drugs, second generation, and now this third generation of anti-epileptic drugs have arrived in the market. Among this third generation in Pakistan, still we have only lacosamide available here, but other majority of drugs from second generation and more broad spectrum like lamotrigine, gabapentin, topiramate, oxcarbazepine, levetiracetam, very important. These are also available in Pakistan. These were the more older drugs, no longer a first choice for long-term management for epilepsy, like phenobarbital, phenytoin, primidone, ethosuximide. It's very good drug for absence epilepsy. Carbamazepine, valproate, and benzodiazepines. So, as we discussed, these anti-epileptic drugs are basically, they target basically that mechanism that we discuss is responsible for pathophysiology of seizures. As we discussed, the pathophysiology of seizures because of abnormal neuronal membrane permeability or because of abnormal synaptic transmission. So these anticonvulsant drugs act to suppress that abnormal membrane excitability or synaptic transmissions. So therefore, some are sodium channel blockers, some are calcium channel blockers, some enhance GABA transmission, some inhibit glutamate transmission because it is very excitatory neurotransmitter. So activity, its Inhibition will cause less postsynaptic potentials like felbamate and topiramate drugs. Drugs that enhance GABA transmission, which is inhibitory neurotransmitter. These include benzodiazepines, barbiturates, valproic acid, gabapentin. Sodium channel blocker drugs include phenytoins, carbamazepine, topiramate, lamotrigine, valproic acid. Calcium channel blockers, again, ethosuximide and valproic acid. This is classification of anti-epileptic medications based on broad or narrow spectrum activity. So drugs with very broad spectrum activity include benzodiazepine like clonazepam, felbamate, lacosamide, lamotrigine, levetiracetam, topiramate. And drugs with narrow spectrum activity are these seizure-specific drugs, especially in absence epilepsy. Ethosuximide is a drug of choice. Unfortunately, we do not have this drug in Pakistan, so we use valproic acid or very rarely lamotrigine for seizure disorders. Infantile spasm, anticotropic hormones, and vigabatrin is given. This is the chart again. In partial or focal seizures, the drugs of choice are carbamazepine, valproate, lamotrigine, topiramate, phenytoin, lacosamide, newer drug. In primary generalized seizures, the more broad spectrum drugs like valproate, topiramate, lamotrigine, zonisamide, and levetiracetam are recommended. In absence epilepsy, you must know in Pakistan we have available valproate, we use it, lamotrigine, ethosuximide, zonisamide, and topiramate. In myoclonic seizures, drug of choice are valproate, clonazepam, levetiracetam, topiramate, and zonisamide. In tonic seizures, again valproate, felbamate, clonazepam, topiramate, and zonisamide. This is again a very important drug line treatment chart. You can see here that only with one drug in most of the patients epilepsy can be controlled. Around 70% of patients you have full control with only one drug. In 30% you may have to use 2 or more drugs to control epilepsy. So principles of treatment should be started with a single conventional anti-epileptic therapy, monotherapy, and the dose should be slowly built until seizure control is achieved or side effect occurs. If first agent is ineffective or poorly tolerated, then monotherapy using another agent can be used. Combination therapy can be considered when 2 attempts in monotherapy with anti-epileptics have not resulted in seizure freedom. Once daily administration should be used with caution in pregnancy. So this is somehow on directions and treatment of a medically refractory epilepsy, those which are not controlled by drugs. These are other non-pharmacological treatment options for epilepsy that include resective brain surgery, ketogenic diet, and stimulators, sometimes deep brain stimulators, vagal nerve stimulation, transcranial magnetic stimulation.